Assalamu alaikum, everyone. Good morning and very warm welcome to all of you at 23rd Shaukat Khanum Cancer Memorial Hospital Symposium. Um, we are your moderators for Gynae Oncology session. I'm Sadia Abdullah. I'm a consultant in clinical and radiation oncology at Shaukat Khanum Cancer Memorial Hospital, Lahore. And I've been joined by Dr. Misbah Masood. She's a consultant radiation oncologist at Salim Memorial Hospital, Lahore. I'm looking forward to a great session today, and we are here to enhance our knowledge in different aspects of gynecological cancers. We'll hear from our experts, Dr. Mansoor Mirza and Dr. Kosanova has already joined us live, and we will be having discussions about recent developments in the state of the art, new surgical approaches in the management of gynecological cancers. We'll also be talking about molecular profiling and precision therapy for gynae cancers. And then we also would like to discuss about the options of fertility preservation in our young female patients suffering from gynecological cancers. We have 4 talks in the session, and we can take questions and answers at the end of each task.
I welcome once again our first speaker, Dr. Mansoor Raza Mirza. Dr. Mansoor Raza Mirza is a leading figure in oncology, especially in gynecological oncology. He is chief oncologist at Copenhagen University Hospital, Denmark, and serves as medical director, Nordic Society of Gynecological Oncology. He is author and co-author of several articles in peer-reviewed publications, and he's principal investigator of several phase 1, 2, and 3 trials, and is the chair of independent data monitoring committee of several international trials. Today, he will take us through the evolving paradigm and recent challenges in the management of endometrial cancer. Welcome, Dr. Mansoor, and over to you, please.
Thank you very much for your kind introduction. Can you hear me?
Yes, we can.
Thank you. And I was asked to talk about management of endometrial cancer, how it is changing and how it has changed in the last couple of years with amazing success. I will first go through the main changes, which are the immune oncology introduction, and then I'll take the future perspectives shortly. So what we had was radiation therapy for early stage or initial disease, but we all know that radiation therapy does not improve survival, but it does improve local control. So that was a limited benefit what we had. The same was the case for chemotherapy. This is the last trial performed where we have tried to reduce the toxicity of chemotherapy moving from triplet to doublet, and it was a non-inferiority trial, so it showed that it was non-inferior. However, as you can see that on the right side, the overall survival, that already at 3 years, half of the patients has expired. So that was for the locally advanced or first recurrent endometrial cancer, quite a pathetic condition. The best thing happened was a decade ago when we saw that cancer genome atlas data coming out in endometrial cancer, showing that it's just not type 1 and type 2 disease. It's a very heterogeneous disease. There is a very small number of patients where tumors are so ultra mutated, called poly, that probably they will not divide and die. These tumors die themselves, and that's why I have an excellent prognosis. And then we have about 1/3 of the patients, almost 1/3 of the patients who are hypermethylated, and they are very susceptible to immune therapy. The rest, there's about 70% of the patients are divided into either here called copy number high or everything else, copy number low. I would call them copy number high to be P53 mute, and the copy number no P53 wild type, and you will see how it shows up in that. So that ended up that we started working on immune therapy in the last decade to see if we can advance the have benefit of immune therapy for our patients with immune checkpoint inhibitors. There was a biological rationale to combine it either with chemotherapy or with PARP inhibitors, and also with angiogenic therapies. And all these I will show how we have moved. Before moving ahead, this is what TCGA told us, that we have a small number of polymute. Here I have put it even smaller. Why? Because the trials we have done is on stage 3, 4, or first relapse. And these tumors do not progress to stage 3 or 4 or first relapse. There are very few patients. And I'll show you that, for example, in Ruby trial of 500 patients, we had only 5 patients with poly. Um, these, these, these are the tumors diagnosed basically in stage 1 disease and some stage 2 disease. And then you have the mismatch repair deficient, about 1/4, and the rest I would call is then we call it mismatch repair proficient, but there is no such terminology. One should call it non-DMMR, and they can be divided into P53 mutant, not specific. That is again a very strange, an SMP is a very strange name. I would call it non-DMMR P53 wild type. And you can see that especially in the P53 mute, a lot is happening. You have HER2, you have PD-L1, you have homologous recombination, repair deficiency, so on and so on. While P53 wild type, which is also most of the part of DMMR population, you have estrogen receptor positive disease. So this is how we are starting to understand the biology of this disease and trying to use that in clinic. We started immune therapy in second line, and in second line we saw that single agent immune checkpoint inhibitors were extremely effective in the DMMR population. So in second line, our standard of care is either single agent weekly paclitaxel or single agent doxorubicin or single agent endocrine therapy. In all cases, response rates are about 10 to 15%. And that was improved in the DMMR population to 45 to 50%. And that's why both European Medicines Agency and FDA approved single agent use of these drugs in the DMMR population. The first phase 3 trial was done in whole population by addition of anti-angiogenic drug, lenvatinib. That drug also working, the combination was also working in the non-DMMR population. And here you can see the results. It is called PMMR. Both overall and PFS are, overall survival and PFS are significantly better, both in the PMMR and all-comer population. So this was the start of understanding that immune therapy is definitely improving the outcome of our patients. And the first thing we could do is move immune therapy up front. And when we moved immunotherapy up front, we did the clinical trials in 3 subsets of the way we did it. First of all, the standard of care is carboplatin paclitaxel in stage 3, stage 4, or first relapse patients, and we added immune therapy to that. So all these trials are plus minus immune therapy on top of chemotherapy, and of course continuing with the maintenance. The difference is that first 3 trials are done in stage 3, stage 4, mostly stage 4 and first relapse. EN11 trial, the B21, is performed in earlier in adjuvant setting, stage 1 and 2 high risk, and stage 3 and 4 no residual disease. And you can see number of patients here. The second question we asked was another 2 trials added, where we have added on top of immune therapy also PARP inhibitors in these trials, and I'll show you results of these trials as well. Last but not the least, we asked the question, do we need to give carboplatin paclitaxel up front? Can we get rid of it? And the LIPO-1 trial was the first one reported in whole population. It's a negative trial. I'll show you in a moment. And the last 2 trials are done only in the DMMR population. Question is, can we omit chemotherapy altogether in the DMMR population. So it's a head-to-head comparison to immune checkpoint inhibitor versus chemotherapy, carboplatin paclitaxel. In one trial, it's pembrolizumab, other is dostarlimab. We don't have results of these trials yet. So what I'm going to do is I will pool all these results together and discuss them according to the molecular classification, because now there are so many results and we have to understand what are we going to do and how we are going to use these. So I will take the DMMR population, and if you look at the DMMR in the early stage population, that is stage 1 and 2, high risk, or stage 3 and 4, no residual disease, that we saw the data at ESMO this year of NGOT EN11, the B21 trial, where you can see that overall trial was negative. You do not see any benefit of addition of immune therapy. However, when we look at the DMMR subgroup, you really see the benefit is coming in 2 years. The progression-free survival is increased from 80% to 92%, which is substantial with a hazard ratio of 0.31, 70% risk reduction of progression in these patients, which is quite beneficial. And that fits very well to all the trials in the DMMR we have done in a more advanced disease, locally advanced or first relapse. Here are the results of RUBY, of DUO-E, of ATTENT, and GY018, and all these Kaplan-Meier curves in the DMMR population. We don't have to see how different it is. Extreme benefit of addition of immune checkpoint inhibitors. For example, the RUBY trial at 24 months, the progression-free survival is increased from 16 months to 61 months, 16% to 61%, which is extraordinary. So that has given approval around the globe of addition of immune checkpoint inhibitors on top of that. Then I showed you the two trials with the results of addition of PARP inhibitors. Here is one, the DUO-E, and you can see that the black line is on durvalumab, and the other line is durvalumab plus olaparib. There is no difference. So do not add PARP inhibitors in the DMMR population. You don't get any more benefit of that. You will only get toxicity. And when we look at the overall survival in this population, these are the curves all for overall. The mature data is from RUBY. You can see that overall survival has increased substantially with a hazard ratio of 0.31, 70% risk reduction of dying of disease by addition of immune checkpoint inhibitors with a hazard ratio of 0.32, which is, again, we have not seen such results before. And I would say that if you take the general population at the median age of 68, and you will see the same survival curves in the healthy population, because one has to die of something. So I believe that we have cured quite many of these patients by addition of immune therapy. As I said, that it doesn't help to add PARP inhibitors, RUBY2, niraparib, DUO-E, the olaparib. We don't see any benefit of addition of PARP inhibitors. Then there was a question earlier that depending what is the mechanism of mismatch repair loss, if it is methylated or non-methylated, the tumors may respond differently to immune checkpoint inhibitors. That's not the case. We have looked at it in the Energy 018. It was presented last year by Eskander, and I presented the data of RUBY trial this year at ASCO. No difference. Both of the subgroups are responding very well to the treatment. So if we summarize the DMMR population, you can see there is a substantial, unprecedented benefit of addition of immune checkpoint inhibitors to chemotherapy, no additional benefit of addition of PARP, and both mutated and methylated tumors are responding equally. Let's move to some questions which are now unanswered. First of all, who are you can see all these PFS curves that first year there's about 1/3 of the population who is progressing. Who are these patients? And that's what we are trying to find out. We are looking at it. Are they double classifiers? Are they P53 mute? Are they some others? so we are not there yet. Second question is, in these trials, treatment is given for 2 years, 3 years, or until progression of disease. Do we really need to give patients treatment so long when nothing is happening after 1 year? So we are initiating a trial to de-escalate the duration of treatment now. It will be comparing 12 months versus longer treatment periods. So I think we do not need to give more toxicity to our patients for more than 1 year when the curves are getting so flat. Let's move now to the mismatch repair proficient disease or non-DMMR disease. And here I will not show you the polymutated data because there are very few patients. The results are extraordinary. In the Ruby Part 1, we had there was only one relapse that was in the placebo arm, and there are only 5 patients. In Ruby Part 2, again, we have 5 patients and no relapses. So that's done. When we look at the poly wild type, we can divide it into p53 abnormal and NSMP. And when we look at the overall survival, here you see the benefit is just modest. In the Ruby trial, you see the overall survival benefit of 0.79. However, this is about 7 months increase in median overall survival in these patients. So that has to be taken clearly understandable. But we still need to figure out, this is a huge heterogeneous, molecularly heterogeneous group. Who are the patients who are really responding by addition of immune therapy? So they're not all patients we are responding. The second thing was that when we looked at the overall survival of these patients, all at that time immune therapy was approved in second line, and more than half of the patients ended up receiving, in the placebo arm, ended up receiving immune therapy with or without lenvatinib at the relapse. And you can see when you have so much crossover, how you can say that overall survival still have effects. And I have looked at the patients who have all the patients only with the crossover, and we can see that all the overall survival in all patients in the patients with DMMR and MMRP, they're all benefiting from first-line therapy, even though there is a crossover in all these patients, as you can see here. So that is telling us that we have to move immune therapy up front. That's the best place. Even you try to give immune therapy at relapse, you do not compensate for the extraordinary efficacy what you receive up front. Then we go to the question of PARP inhibitor back in the pMMR population. Now it's not the DMMR. In DMMR, we didn't see any benefit, but in pMMR, you start seeing benefit. I won't discuss Ruby. We still have to get more mature data to compare with Part 1. But in DUO-E, you can see how by addition of olaparib here to durvalumab, you have pulled the curve up. However, the trial was not powered to show the difference between arm B and C, but still hazard ratio has moved down to 0.57, and that's why European Medicine Agency has approved this regimen to the patients who are pMMR in locally advanced or first relapse of endometrial cancer. So which are the patients in the who are responding to chemotherapy plus minus PARP in the pMMR population? And we did the molecular classification in the Ruby Part 1 and Ruby Part 2. And we can see in both in Part 1 and Part 2, Part 1 is with dostarlimab immune checkpoint inhibitor on top of chemotherapy. And you can see in the p53 mute population, hazard ratio of PFS is 0.55, quite a substantial increase, while not really big benefit in the NSMP. While on the right side, you see Ruby Part 2, and there you can see even higher benefit. Numbers are small in p53 with a hazard ratio of 0.29. And NSMP is also moving to the right direction with 0.61. Oh, I have 1 minute left. Results by mutational study, I will run away with that. so the patient characterization in the MMRP population would be that we do see benefit in the MMRP population, but most of the benefit is probably coming from the P53 abnormal patients, not in the NSMP, and we have to dig into data on that. And remember, when you're adding PARP inhibitors, you are adding toxicity. On the right side, you can see that 14% of the patients as compared to 6% discontinued treatment in the maintenance arm by addition of PARP inhibitors. And the last question was, can we get rid of chemotherapy? And these were the last 3 trials. And unfortunately, the trial with lenvatinib pembrolizumab against chemotherapy is negative. There are some subgroup analyses. I'm not going to discuss that. So where are we moving from here? We are moving to understand the biology of disease and try to use that in clinic. We have in the mismatch repair proficient P53 wild type population another drug, the selective inhibitor of nuclear export, and we saw the SIENDO trial. Overall, the trial was negative, but when they looked at the data of P53 wild type population in as whole on the left or in the NSMP population, you see a huge benefit in this subgroup, and that's why our phase 3 trial is ongoing in P53 wild type population only. We have looked at the HER2 data. Lately, we saw the results of antibody drug conjugate TDXD, which showed that if patients had, these patients are mainly in P53 mutant population. If they are HER3 3+, they have extraordinary benefit with 85% response rate, and that's why FDA has approved tumor agnostic TDXD to all patients who are HER3 positive. We are trying to add CDK4/6 inhibitors to letrozole, again in the ER positive patients in endometrioid. We have initial signal of activity where we have to do a phase 3 trial to come up to that. And my last slide is the tsunami of ADCs, which is coming in, which is amazing. That's the next big thing which is happening in gynae cancers. We have altogether, we have about 90 ADCs being introduced to oncology, 30 of them in Gynae Oncology. And this is just one example. We are just initiating the trial of TROP2 inhibitor, which is recruiting well. So thank you very much. My last slide would be, first of all, you must perform molecular classification up front, rather at the biopsy than the surgery, because your treatment will be dependent on your molecular classification. And immune checkpoint inhibitors have completely changed the standard of care for our patients, and we are moving ahead. Thank you.
Thank you very much, Dr. Mirza. It's always a delight to listen to your talks, and I wish we had some more time just to listen to your talk a bit more, maybe in future. Thank you very much for joining us live from Geneva. Next, we are going to move on to our next talk. It's from Dr. Nadeem Abu Rustam. He's a director of minimally invasive surgery and professor of gynecological cancers at Memorial Sloan Kettering Center, New York, USA. He has more than 34 years of experience and has extensively published in high-impact international journals. He is going to talk to us regarding results of sentinel node mapping in endometrial cancers. I think we are having a bit of technical issues, so we shall move on to our third speaker, who is Dr. Rabia Mushtaq. Dr. Misbah is going to introduce you.
Female cancers during reproductive years poses significant challenges, and these will be addressed today by Dr. Rabia Mushtaq, who is consultant gynecologist and obstetrician, Shalimar Medical Center. And she has more than 20 years experience in this field and is trained in the field of infertility in the International Guy's and St. Thomas Hospital. She's author of MRCOG book and has published several in several medical journals. I welcome Dr. Rabia Mushtaq. Please welcome.
Thank you very much. It's a pleasure being here. And I think today I would be bringing things from a slightly different perspective. The audience includes oncologists, people who deal with cancers every day, and then the gynecologist. Some of us get to deal with the reproductive medicine and see the aftermath of cancers. So I also want to bring the situation in Pakistan, how it is going, rather than just what is happening on the international forum. So I have been working in Pakistan for the past 3 years. And while I see a lot of patients coming for IVF for fertility to have babies, in the past 3 years, I have not yet seen a single patient coming for ovarian tissue preservation or for oocyte preservation because they have been diagnosed with cancer. And I feel that it's a very devastating situation from the point of view that care in cancer has improved so much with the passage of time that there is hope for them in future. There is a possibility for them to have children later on in life. And it can only happen if we can point them in the right direction. I was just talking in the morning and saying, it's such a devastating diagnosis here in Pakistan, even now, that when somebody is diagnosed with cancer, that they forget that there could be something more beyond this, as a result of which they are not thinking of their fertility. I think as a physician, because when we are standing outside, it's easier for us to point them in that direction. So, and that's the main purpose of this presentation today, that I wish that it becomes a part, it gets integrated into our practice, because it also gives them a hope for future. It gives them a hope to see that, all right, this is happening, but the doctor is talking to me about my future. So there is some future in it. And I hope that this can happen on a routine basis. So I think this is like preaching to the converted. We all know that there is some evidence about association of testicular cancer with subfertility. I myself have seen patients, a young lad coming with 23 years of age, recently married, diagnosed with azoospermia. And when we were doing the workup, we realized he's got a testicular mass. So sometimes it's the other way around, that I should be thinking, if somebody is coming with a fertility problem, could it be predisposing them to a cancer, or what is going to be their future? So my job should be not just looking at fertility, but their future from there onwards as well. So there is some evidence about prostate cancer and melanoma. I won't get into the detail of it. We do know that for female cancers, anovulation or polycystic ovaries have been associated with endometrial cancers, and then ovulation induction and later some ovarian cancer. But it's a matter of debate. If you look at the studies, initial studies said that it is the case, but later on this has been refuted. So again, that's more your field rather than mine. But it is my job to think about it when a patient comes to me, that what does future hold for it? When a woman comes with polycystic ovaries and she is obese, then she has a continuous estrogen exposure. It is my job to think what is going to be her future as well. My counseling needs to include that. What should she be thinking of for her future? What are the risks that are there for her? So that is the part of a gynecologist, I feel, that needs to be fulfilled. We need to be looking at it in more detail as well. So as I said, think of the risk for future during a reproductive consultation. Just as abnormal semen can be a reflection of a man's overall well-being, similarly, inability to conceive for a woman can be a reflection of her overall and future well-being. And we should risk assess. As gynecologists, we should risk assess those patients. Also, from the point of view of gynecologists are the doctors where females that encounter female population the most. Even if it is a lump in the breast, their first stop is usually a gynecologist. It's very important to include in your gynecological examination at your first antenatal checks, a breast examination, at least a breast examination, because that is a risk that we can reduce. We are in contact with that population, and if we can help with that, it would be. And I have seen breast cancers being picked up at the first antenatal check or at the first antenatal contact. So I feel part of it is, what can we do to bridge the gap that is there, and that is, I feel, our job as gynecologists. So what's the condition? So this is a borrowed slide. And this is about how are we doing in terms when it comes to advanced modalities for fertility treatment. So if you look at the numbers are such that IVF cycles per year that are being performed per total population. The comparison is with UAE, Saudi Arabia, Egypt, Iran, and India. And then look at us, Pakistan, 7,000 cycle per year for our population. Where are we? So we are unable to provide a fertility treatment. I understand that UAE, KSA have got better economic conditions. India, not so much, but still, well, I shouldn't say it anymore, but anyways, even when they were not, the treatment was more readily available. And there was more uptake for cryopreservation for the eggs as well as for the sperms as compared to us in Pakistan. It is still a novelty. It is still something that we have to remind ourselves every time that this is something that we need to think of. So a total number of 7,000 cycles are being done in Pakistan. If that's a devastating difference, that we are unable to provide our population with the care that should be there, whether it's government support or however we manage it. But that these are the numbers. So concerns about fertility preservation in cancers, what are we thinking? So is it the cancers which is reducing the fertility itself? Yes, they do. Then the exposure to the chemotherapy and then the pelvic radiotherapy. My question to you is, can you spare 2 weeks? Is it safe for your patient to be spared for 2 weeks in order to have egg preservation? Bear that in mind, that they are going to be exposed to estrogen for those 2 weeks. That may increase their risks, and you may think that it is not safe for them to do so. But looking at the numbers, when I was working in Guy's and St. Thomas, we would be getting at least 6 patients per week for fertility preservation, where from the diagnosis, they were sent in directly to the center to start the treatment. We can start the cycle randomly. We can start at any phase of their periods. It does not have to be day 2 of our periods. We can start the day they come to us. We can start the procedure, and within 2 weeks, they would have their eggs freezing. If the couple is married, then we can do the embryo freezing for them, which has a better survival and survival rate when it comes to the freeze and thaw process. And if it is still an unmarried girl, I understand that there are some social issues as well. For example, the egg collection is done vaginally, and then there is the society is thinking of a virgin having a procedure done transvaginally. That itself becomes a problem. But again, there are ways we can bypass that, and there are ways by which we can do a repair later for the girl as well, if it comes to that. But we need to give them that option. So to all of you who are involved in seeing patients with cancers, my plea is, if you can spare 2 weeks for a woman, for a girl who has not have her, whose family is not complete, 2 weeks period to have her eggs frozen or to make embryos, then please do offer it. Because I have not seen any patient coming for egg preservation, but yes, I have seen patients coming to us after chemotherapy, after radiotherapy, who now want to conceive, but their anti-Mullerian hormone level is so low that we are unable to help them anymore. So if we can avoid that, and for that, I think I need help from the best center in Pakistan to increase that referrals. And I think I come here with that plea today, that please talk to your patients about it. And we'd really appreciate it. if we can do this for them. Similarly, I think I do not need to emphasize it much. When it comes to men, all it takes would be 2 days to go give a semen sample and then another sample the next day. So it's probably relatively easier to freeze semen, to offer cryopreservation to men as compared to it is for women. However, again, I say, all it takes is 2 weeks. If you can spare it, oncology is not my field. You may think it's not safe to do so, but at any point you feel it is safe. Before that patient is going to go for chemotherapy or radiation, please do think about it. Now we have started offering even ovarian tissue preservation for young girls who are prepubertal. So the whole ovary can be laparoscopically retrieved and frozen. Slices can be taken and frozen, even for prepubertal stages. So that is something in infancy in Pakistan, but still an option available. So something may come off it for future, and I think it's really important that we think about it. So the egg freezing, let's say you are sending to me a patient who is 40 years of age and he's coming to me for egg freezing, then I think it's really important that we are realistic about it. What do we get out of it, and what is the expectation? So optimal number of the eggs frozen achieved. As age under 34, the rates are very good. So more than 74% of the patients, we get optimal number of eggs out of a single cycle. As the age advances, the number of the eggs, that optimal number, are going to go down. Bear that in mind. There are 2 factors. Number 1 is that the quality of egg is going down with age as well. And also the numbers that we are going to retrieve are going to go down. However, the numbers that we need are going up actually, because again, the quality is going down. So for a young woman under the age of 35, sometimes getting only 3 eggs is good enough for us. So 3 to 8 is the number that is needed for somebody under the age of 35. However, when the age goes up, then the number could be required is about 15, which is less likely that we would be able to offer at the age of 40. So when I talk about a consultation for an egg preservation, which the only cases that I've seen up till now are for social egg freezing, for somebody who's not getting married at the right time, feels the clock is ticking, I may not get married soon, I want my egg preservation. Those are the cases that I seem to be seeing rather than the cancer patients. But I do try to tell them at that point, it's really important to be realistic about the numbers that you would have, because if you are at age 40, your one cycle may not be able to help you. But that is something which we will not have an option in cancer patient. I can't ask a cancer patient to come for multiple cycles. So at least if we can offer it to all, and we try to recommend that option to patients under the age of 35 to do that if their family is not complete.
Dr. Rabia, 1 minute left.
And the last slide.
Thank you.
So the best time to freeze eggs was 10 years ago, and the second best time is now. Thank you.
So next we have results of sentinel node mapping in endometrial cancer by Professor Nadeem Abu Rustam. He is Director of Minimally Invasive Surgery and Professor of the Gynecological Services at Memorial Sloan Kettering Cancer Center, New York, USA. Dr. Nadeem Abu Rustam.
Honor and privilege to give you this update on the evolution of surgical staging for endometrial cancer into an image-guided precision surgery with enhanced pathology, looking beyond white light and the naked eye at staging endometrial cancer. The majority of patients who present for surgery uterine confined disease, at least apparently on exam. And the main objective of the surgery is twofold. One is to remove the tumor with a hysterectomy and usually removal of the tubes and ovaries, and then find out if endometrial cancer cells have spread outside of the uterus. That's why we do pelvic washings, peritoneal biopsies, or mental biopsies, and remove lymph nodes. Lymphadenectomy in the staging of endometrial cancer has really, for us now, become bilateral sentinel node mapping. Lymphadenectomy for staging was not included in the primary management because it made people live longer. It should be reserved for clearance of gross nodal disease, or if you fail to do sentinel node mapping. So lymph node staging for apparent uterine confined endometrial cancer can be safely done by using the Memorial Sloan Kettering sentinel node mapping algorithm. And to date, removal of normal appearing lymph nodes has not been shown to make people live longer. And again, there are fewer and fewer cases of complete pelvic and periodic lymphadenectomy for staging endometrial cancer. So if you do not do any nodal staging for apparent uterine confined disease, I think you can escalate to sentinel node mapping. And if you are doing complete pelvic and periodic lymphadenectomy for staging, you can de-escalate to sentinel node mapping. There are fewer and fewer periodic nodal sections done for staging. We believe that women with endometrial cancer should be treated by gynecologic oncologists. And again, staging with the Memorial Sloan Kettering SNN algorithm resulting in bilateral pelvic nodes in the majority of cases. So when the patient leaves the operating room, at the minimum, you have bilateral pelvic nodes, usually sentinel nodes. And the SNN algorithm with bilateral pelvic node dissection and ultra staging appears to be superior to our historical pelvic lymphadenectomy data as far as detection of metastatic disease. It's because of increased precision in the OR and also enhanced pathology by our pathologists. As far as imaging, PET scans for clinical stage 1 disease have a very high false negative rate. So surgery remains the gold standard for detecting microscopic disease. It is okay to do imaging, but it's very unlikely you're going to find small metastases in lymph nodes with the available imaging. Our algorithm can be used in all grades and in all histologies. And again, unless you've done a hysterectomy and you have final pathology, it is not possible for us to determine the incidence of pelvic nodes. However, if you have a full hysterectomy and final pathology, there are formulas like the one by Dr. Beach and co, where you multiply 3 by grade by numerator of depth of invasion and calculate the possibility of lymph nodes in the pelvis. But the vast majority of patients, we are not able to do that. Again, you can say, well, why are we doing this for grade 1 and grade 2 endometrial cancer? Well, in the GOG study with endometrioid cancer, almost 1,000 patients, 60% of those who had positive lymph nodes were low grade, grade 1 and 2. And you can say, well, why are we doing nodes for grade 1 and grade 2? Well, because you don't know if there's lymphovascular invasion. Whenever lymphovascular invasion is present or detected, even in low grade, superficially invasive, less than 50%, nodal positivity can be at least 10%. This is data from our institution, endometrioid, almost 1,000 patients with bilateral mapping. You can see in the low grade, grade 1 and 2 endometrioid, with superficial invasion, this is with or without lymphovascular invasion. Nodal positivity is around 5%. And of course, if you add lymphovascular invasion, this doubles. So really the concept of removing lymph nodes for staging has evolved from counting of lymph nodes 20, 30, 40, to really bilateral sentinel nodal detection. It's about the quality, not the quantity. So it's a change in surgical culture. The goal is really to find the positive microscopic lymph nodes. It really depends on what you do in the operating room and how the pathologist looks at that. So we have shown a long time ago now that even with blue dye, when you inject the cervix, those blue lymph nodes are 3 times more likely to have cancer than the non-blue nodes. And this is without ultrastaging. This is just by H&E. So there's increased precision when you inject the cervix, you follow the dye, you remove those colored lymph nodes. It's 3 times more likely that you have metastasis in them. So increasing precisions. Nowadays, we've switched to indocyanine green, which is a very powerful dye, and we use laparoscopy with a laser. We inject the cervix at 3 and 9 o'clock. We inject 4 cc's total. We usually do 1 or 2 cc's superficial at 3 and then also at 9 o'clock. In the past, we used to do superficial and deep, but with ICG, the dye is very powerful, and this is the type of injection that you want to do. And then you can also inject 4-point, but most of us are injecting at 3 and 9. And with the availability of the fluorescent imaging technology with near-infrared imaging, like this Tracker Novadax system and others, the images are incredible to see. We've done a randomized trial of blue versus green dye. ICG is superior to blue dye in identifying sentinel nodes and bilateral sentinel nodes. You don't need to mix blue and green. It identified all the metastatic nodes. And again, we validated that the interstitial injection of ICG is safe. We still have the problem of the surgeon removing something that's colored, calling it the lymph node, and on the final pathology, it's a piece of fat or a channel. This is called the anti-package, so you have to be careful with that. So ICG is a very powerful dye, but not everything green is sentinel node. You really still have to follow the anatomy and find your channels using the proper technique. You have to be careful with this anti-package problem. And again, surgical innovation can be a problem. Things can be expensive for users throughout the world. The current platform allows you 4K high definition image. On top of that, you have the SPY mode, which is the black and white mode, and then you have the pinpoint mode, which is this a computer overlay with green, and then you have a heat map, a color segmented fluorescence. So we don't use technetium anymore. It's all using color dye and high definition images to help us with that. And as you toggle through these, you can find good chance. Indocyanine green is very, very safe. Allergic reactions are incredibly rare, and we've done thousands of patients with excellent results. The Memorial Sloan Kettering sentinel node algorithm was published in 2012 and included in the NCCN guidelines in the principles of surgical staging in 2014, and it's outlined here. You do a cervical injection, you do peritoneal and serosal evaluations and pelvic washings. You start by removing the sentinel nodes. And again, you excise the sentinel nodes at any suspicious nodes. And if there is no mapping, you do a site-specific lymphadenectomy. The periodic dissection is left at your discretion. Most of us now do not do periodic node dissections for staging unless the sentinel node maps to the periodic area. So these are the main elements of the aesthetic count. Of course, if you start the operation and there's peritoneal disease, you do not do sentinel node mapping because these are stage 4 patients. You don't need to remove the nodes for staging. If you have enlarged bulky nodes, again, you don't do sentinel node mapping, you remove those grossly enlarged nodes if you can. If there is no mapping on one side of the pelvis, you perform a site-specific lymphadenectomy. We call it a type 1 dissection, basically median to the external iliac, ventral to the internal iliac, superior part of the operator space, and also check the common iliac pre-statement area. Now, since the Memorial Sloan Kettering algorithm in 2012 and the SEMPI Endo French study also around that time, the adoption and utilization of sentinel node mapping in endometrial cancer has really skyrocketed. And I think most programs are using this. So these are some 10 tips for finding pelvic sentinel nodes. And again, do a good injection technique, keep the surgical field clean. Always do the nodal mapping first if you can, unless the uterus is too big, is in the way that you do the hysterectomy. Be precise and slow down a little bit, divide the round ligament, find the obliterated umbilical. It's the most important landmark. Follow it cranially, develop the paravesical and pararectal spaces, find the lymphatic trunks crossing the umbilical, usually from median to lateral. And there's a common mapping pattern that I'll show you, and then there's a less common pattern if you don't see the usual chunks in the anterior paracervical pathway. This is the most common mapping. Again, this is with blue dye. This is the anterior paracervical pathway, pre-ureteric. The dye condenses in the cervix following the cervix injection, crosses from medial to lateral, crosses over the umbilical, and your sentinel nodes are usually medial to the external iliac, ventral to the internal iliac, superior part of the umbilical. And again, on the left side, you can see here where the yellow arrow is, this is not your sentinel node. This is a tertiary lymph node. The sentinel node is where the instrument is showing. It's the one just lateral to the left obliterated umbilical. So you find your umbilical, you see the dye crossing from medial to lateral. This is on the left side. This is your true SLN, and then you can have secondary and tertiary. So the caution is that somebody will see something, bring and remove it and call it sentinel. That is incorrect. You need to open up the spaces, find your trunks, follow them, and take the most proximal. Again, on the left side, this would not be your sentinel. You have to dissect, open up the spaces. This is your sentinel node. It's below the left external. On the right side, this is the sentinel, secondary and tertiary. You don't need to remove secondary and tertiary, but if you remove them, call them secondary and tertiary, don't call them sentinel. The one in red is the actual sentinel. These are the two mapping patterns following a cervical injection with a dye. On the left in blue is the anterior paracervical pathway, the most common, 95% of the time. The one in green is the posterior paracervical pathway, retrourethral, where the dye does not cross over the umbilical, but goes to the presacral common iliac area, about 5%. And again, this is an example of the less common mapping pattern. The dye is not crossing over the umbilical, but going to the presacral common iliac area. It's in the mesoureter. You can see it here, and ends up in the presacral common iliac area. This is about 4 or 5%. The majority of patients with map in the anterior paracervical pathway. The beauty of sentinel node mapping is it avoids the traditional lymphadenectomy template, because most of your sentinel nodes are going to be cranial to the round ligament, so you can avoid the deep circumflex iliac lymph node, that lymph node that we described in 2007, giving you leg lymphedema. So it's a large lymph node. We usually would remove it historically in pelvic lymphadenectomy templates. The reason it's large is because it's draining the vulva, the mons, the legs. So again, removing it will increase your risk of lymphedema. With SLN mapping, you're almost always avoiding this. Our colleague Mario Lateo did a survey with patients, 623 patients, to really assess lower extremity symptoms based on folks who had sentinel nodes versus lymphadenectomy. And again, SLN mapping by patient-reported outcomes independently associated with a significantly lower patient-reported leg length. So we have data from patients that sentinel node mapping decreases the risk of lymphedema. Our colleagues in Brazil also looked at whether or not SLN mapping decreases the risk of lymphocyst formation, and again, it did compared to full lymphadenectomy. So we're decreasing side effects, increasing precision. Now, we know that if you have negative bilateral pelvic nodes, the chance of a periodic skip metastasis is less than 5%. It's probably 0.9% in endometrioid, and in non-endometrioid, it's about 2 to 3%. So this is a risk that we live with. But I think what happens is, as we get better at doing bilateral pelvic nodal staging, the concept of an isolated periodic nodal metastasis would decrease time. These are our colleagues in the Mayo Clinic. They took folks who had isolated periodic nodal metastasis, they ultra-staged the pelvic nodes, and they found that they missed 30% without ultra-staging. So the more effort you put into precisely finding lymph nodes in the pelvis and doing ultra-staging, the concept of isolated periodic metastasis decrease with time. Over the last 10 years, we've done 6 studies in collaboration with the Mayo Clinic comparing sentinel node mapping at Memorial with the traditional open pelvic and periodic lymphadenectomy at the Mayo Clinic. And I can summarize these 6 publications that they were all favorable and all very reassuring, comparing sentinel node mapping to traditional lymphadenectomy done at the Mayo Clinic. We've used sentinel node mapping in endometrial serous cancer. This is our first report from 2017, which was also reassuring sentinel nodes versus lymphadenectomy. We published again an updated series of 245 patients with endometrial serous cancer pure SLN mapping, even without periodic resection, to lymphadenectomy, pelvic and periodic. And you can see this data from 2021 is very reassuring. And these are the survival curves, overall survival curves, no difference. So in our practice, the Memorial Sloan Kettering SLN algorithm has replaced systematic lymphadenectomy as the primary staging modality in endometrial serous cancer as well. The same with carcinosarcoma. This is our original report, no difference between SLN and standard lymphadenectomy. And again, updated series from 2022 from our institution. This is 99 cases with sentinel node versus 100 with lymphadenectomy. You can see overall survival, progression-free survival, really no difference between lymphadenectomy and SLN. Finally, the study that we're doing right now is really looking at endometrioid only, clinical stage 1. It's a surgical study called the SELECT study. We're looking to assess 3-year pelvic non-vaginal recurrence in women with endometrial cancer. They have to have low grade with deep invasion, meaning 50% or more, or high grade, grade 3 with shallow invasion. This is endometrioid only. They have to have bilateral negative SLN, also negative washings, and they are treated with surgery alone or surgery plus vaginal brachytherapy. External beam radiation and chemotherapy are not allowed. So we're trying to accrue this cohort and look at the risk of pelvic non-vaginal recurrence to really show that in endometrial cancer, this operation provides good oncologic outcome with very low nodal recurrence rate. The study is ongoing. And again, this is the adjuvant treatment. It's either observation or vaginal brachytherapy. There is no chemotherapy or external radiation. It's a surgical study plus or minus vaginal brachytherapy. So for future directions, this is what we're doing. We're trying to also improve prognostication using the primary tumor with molecular profile, improve the understanding of tumor nodal interaction, improve our understanding of low volume metastases with isolated tumor cells. And again, trying to improve the detection and understanding of non-sentinel node metastases, peritoneal metastases, etc. So we are continuing to increase mobility and increase precision in surgery. So we are moving in the right direction. There is increasing precision in surgery with sentinel node mapping algorithm. Women with endometrial cancer should be treated by gynecologic oncologists. Sentinel node mapping is our current standard, and I think it's the standard in many places, in many societies, and most guidelines. Near-infrared imaging is done by plastic surgeons and allows us to see beyond white light. And thank you so much for the opportunity to be with you. And I wish you the best for the meeting, and hopefully we can join you in the future in person. Thank you.
Thank you, Dr. Abu Rustam, for such an excellent and informative talk. And use of robotic systems to perform complex procedures. Use of robotic systems to perform complex procedures with precision and control represents the most significant advancement in gynecological oncology. To talk about this interesting topic, I welcome Dr. João Casanova, consultant obstetrician and gynecologist, Hospital da Luz, Lisbon, Portugal. He completed his fellowship in Memorial Sloan Kettering Cancer Center and has many publications in international journals. Over to you, Dr. João.
Hello, good morning. Directly from Portugal and Lisbon. My name is Gynae Oncology. I'm the head of Gynae Oncology unit from the Department of Obstetrics and Gynecology at Hospital da Luz in Lisbon. It's my great pleasure and my great honor to share my experience with you in robotic surgery in my field of expertise, which is gynecologic oncology. These are my disclosures, and one disclosure that is not mentioned here is that I'm very, very huge fan of robotic surgery. A brief agenda. So I'm just going to introduce you a little bit to my reality, to my hospital and my institution. I'm just going to share with you also a little bit of my challenges in building a robotic program in gynecologic oncology in the private setting. Share data out there and review a little bit of the literature about robotic surgery in gynecologic oncology. I'm just gonna try to show you my experience from more than 650 robotic surgeries and just a couple of take-home messages. So on the picture on the right side, you see my institution. So we're the largest private hospital in Portugal. We are almost 500 bed hospital. We have 17 operating theaters. We have one Da Vinci Xi and a well-established robotic program since 2013, especially in urology. We have a second robot coming when I hope that it's the second Da Vinci Xi, but we're also trying to analyze the benefits of having like the new Medtronic robot. A little bit on my hospital, we have residents in almost every specialty, and we're expecting our first residents in OBGYN in 2025. We're part of the biggest private health system in Portugal, and we're the first private academic center in Portugal. We have a medical school, which is called Kent Medical School, and we're very happy to have students with us. So looking a little bit more in detail to my department, of last year, we had 4,000 deliveries. We're the largest maternity in Portugal, including the public sector. We have all areas of the field of obstetrics and gynecology. We have had last year roughly 80,000 outpatient visits per year, and we performed the whole department almost 2,000 gynecologic surgeries. So looking a little bit more in detail to my unit. So I started in May 2022. Before, it was almost residual to non-surgical activity. So we're two attending surgeries. Surgeons, one is still in training. We have rotating residents, and we perform and we take care of patients in all areas of the field. So we perform robotic surgery, we perform cytoreductive surgery, multivisible section, we perform HIPEC, we perform open surgery when needed, we perform laparoscopy, and we perform more than 220 surgeries in this last 2 years. So one of the challenges that I faced when I came to my institution was to build a robotic program in gynecological oncology. So there was no surgical robotic surgical activity in any of the fields in my department. So I had to deal with patients, with insurance coverage, and also with the hospital. So I think the picture on the right kind of translates the difficult environment and also the very thin equilibrium between all these stakeholders. So my hospital charges extra fees for robotic surgery. Insurance coverage is very confusing in Portugal. So even for documented malignancy, some insurance companies do not cover for the use of robotic surgery. They call it experimental. For complex benign gynecologic disease, it's even more challenging. And so the patient sometimes has to pay out of pocket. So I would say in one word, the main challenge in building the robotic program in Gynae Oncology is money. So in terms of literature, what's the evidence of the benefits and the usage of robotic surgery in my field of expertise, which is gynecological oncology? So we need to go back to 2009 and 2008. I'm going to focus a little bit on the DOD Lab 2. So basically, laparoscopic surgery was considered the standard of care for endometrial cancer. It had the same oncological outcomes in endometrial cancer when compared to open surgery. They considered that it was feasible, safe, with less complications, and better quality of life for patients. And so I could say that from 2009 onwards, MIS became the standard of care for endometrial cancer. This paper analyzes benign gynecological pathology, especially benign hysterectomies. And I always like to come back to this paper because it shows one of the main advantages of performing robotic surgery, that you can move safely your patient from inpatient to outpatient. If you look at both of the graphics, you're going to see there's a trend to move hysterectomy toward the outpatient setting. And this was by the conclusions authored because the rates of either laparoscopic hysterectomy or robotic hysterectomy significantly increased in this time period. There was a significant shift from inpatient setting to the outpatient setting. And these findings suggest that robotic hysterectomy may facilitate the shift to outpatient benign hysterectomy, particularly for patients with complexity. So, what about in my field in gynecological oncology? this was published by my former group. I did my fellowship in Gynae Oncology in Memorial Sloan Kettering in New York almost 10 years ago. So they looked at 200 robotic hysterectomies. Almost 50% had a diagnosis of malignancy, 45% had complex procedures defined with at least lymph node evaluation, and almost 80% was discharged from the scene. This is a landmark paper published in JAMA Surgery in 2019, and basically this is a study coming from Denmark, and they did a nationwide introduction of minimal invasive surgery, namely robotic surgery for early stage endometrial cancer, and they tried to see what happened to the risk and the incidence of complications. And basically, the introduction of this approach changed the landscape, and it moved completely from open surgery to robotic surgery or minimal invasive surgery with a significant reduction in the risk of complications. Another paper from my former group from Memorial Sloan Kettering Cancer Center. So they looked at elderly patients as they perform surgery for endometrial cancer. We do have patients that are postmenopausal, so we do have to take care of elderly patients. So they looked at three groups of patients, 65, 74, 75, 84 years of age, and older than 85 years old. Almost 1,000 robotic surgeries, 72% had a diagnosis of malignancy, and most of them endometrial cancer. And they found out that robotic surgery was safe in elderly patients. And of course, there was an increased risk of unfavorable outcomes in that group that was 85 or older, which is also true for vaginal surgery, open surgery, or all kinds of surgery. So from my practice and my experience, what I can share with you is that robotic surgery is an amazing, let's call it, weapon to have when we face severely obese patients, especially with endometrial cancer. We know that obesity and endometrial cancer come and walk hand in hand. So robotic surgery in the severely obese patients with endometrial cancer is feasible. It's highly reproducible and could be a valid alternative to laparoscopy in these patients. With what we all want with it, will reduce the risk of conversion in this patient and reduce all the risk of post-operative complications. So moving from endometrial cancer to ovarian cancer, which is my main area of expertise. So I would say that robotic surgery in ovarian cancer, the evidence in the literature is growing. And there are ongoing trials, even in the advanced setting, either as primary debulking surgery using the robot, or in the context of neoadjuvant chemotherapy and in interval thyroidectomy surgery. So data on minimal invasive surgery in selected cases of early stage ovarian cancer, it's more robust because we have the experience previously with laparoscopy. In the recurrent setting, there are also some publications, but I have to stress it's highly selected patients, and we need to have very well-trained surgeons to perform these kind of procedures. So I'm just going to show you very briefly two trials that they looked at robotic surgery and the interval thyroidectomy surgery setting in advanced ovarian cancer. 91 cases, 57 underwent robotic surgery, 82% underwent a complete growth resection surgery, and it's highly comparable with data from open surgery, and which is amazing. They spent 1 day at the hospital. Another study, this one coming from China, robotic surgery in the same setting, 93 cases, almost half of them underwent robotic surgery, and they concluded that the use of robotic surgery did not affect the bulking success or any oncologic survival data. So this is highly interesting and highly promising. In cervical cancer, so we're now facing a clinical dilemma. So we had this very important trial published in 2018. It was so important it was actually mentioned in the New York Times. So the LIFE trial, I'm pretty sure every one of you is aware of the main findings of this trial. So basically, either laparoscopy, robotic surgery, radical hysterectomy, or early stage cervical cancer had worse oncologic outcome when compared to open surgery. So we now, outside clinical trials, cannot offer to patients radical hysterectomy. Our hope is that the RAC trial, which is analyzing only robotic surgery in expert centers, will probably shed some new light and probably will allow us to perform specifically radical hysterectomy in cervical cancer using the robot. So I have to say that I'm heavily biased because my training and all my practice is with the Da Vinci Xi. So according to what I was trained, we use a straight line port placement. Trocar should be placed a little bit higher up than conventional laparoscopy, about 18 to 20 centimeters from the cubic symphysis, meaning you should just go above the umbilicus. If you're planning to do periordic lymph node dissection, you should go closer to the umbilicus, and you should place your trocars. The recommended distance is 8 centimeters, but between 6 to 10 centimeters, it's also acceptable. I'm going to show you a picture of this is the standard trocar placement for, I would say, 90% of my cases using the robot, specifically the Da Vinci Xi. You see the robotic trocars, metallic ones are placed in a straight line, and you have the assistant trocar placed a little bit up on the upper left quadrant of the eye. So from my experience, which is, I want to say considerable, I've done more than 600 robotic surgeries, all with the Da Vinci Xi and some with the Da Vinci SI when I was doing my training in New York. 60% had a diagnosis of malignancy and or needed protein section. The median length of stay is 1 day, and I can do better. I think it should move towards same-day discharge. I had 1 day back, no conversions. It allowed me to do more precision medicine, especially do sentinel lymph nodes in endometrial cancer. So what I wanted to share with you my practice and my current unit. So we've done 8 robotic surgeries. We started from scratch in roughly 2 years. The median surgery is 57.7 years. This is in accordance with Gynae Oncology, so our patients are older. Mean BMI 28.05. We also operate on heavier patients that have endometrial cancer. Most of them were pretty healthy, and most of them, almost 98%, were at ASA1 and ASA2. So on the right-hand side, you have a video of the periodic lymph node dissection. You see the ureter, the right ureter is lateralized, and I'm doing right periodic lymph node dissection. And you see the advantages of the robot, which is precise dissection. You can move around. You don't have constraints of conventional laparoscopy. So looking back, the mean length of surgery is 165 minutes, which is pretty acceptable. Of course, we have some long cases when we have to do a cycloreductive surgery with extensive periodic lymph node dissection. There are longer cases. The mean EBL, we're very happy. 45 cc's, it's pretty standard and according to the literature. The median length of stay, I think we can do better, 1 day. And from patients that chose to go home on the same day and patients that stayed a little bit longer. We had 4 patients that stayed 2 or 3 days due to the length of surgery, due to the extensive procedures that were done in those surgeries. And we had a patient that stayed 2 days because she wanted, so she was feeling comfortable and she wanted to stay with us longer. In terms of complications, we had 1 case of a complication greater than grade 3 of the cleft window classification. It was a patient that underwent a simple hysterectomy with proton section, and it came out benign. The patient had a bladder injury that was not detected during surgery, was only detected on post-op 5. So the patient underwent surgery and repair. Unfortunately, she developed a vesicovaginal fistula, but for now she's asymptomatic. So we had no conversions for laparotomy. 47% had a final diagnosis of malignancy. 67% had a diagnosis of malignancy and or needed proton section. And we had a couple of risk-reducing surgeries that are also part of the spectrum of the field of expertise of the Gynae Oncologists. So most of malignant cases were endometrial cancer. Looking a little bit to some issues that kind of translate if we're doing good surgery or not. 100% of our patients underwent sentinel lymph node dissection. 100% had at least unilateral mapping, and 90% with bilateral mapping. We had some cases of early stage ovarian cancer, and we had a case of recurrent ovarian cancer, and we had a couple of cases with early stage cervical cancer that underwent simple hysterectomy and a case of leiomyosarcoma. So most of the procedures were hysterectomy, salpingo-correctomy, sentinel lymph node. We had a couple of cases that we had to do sort of pelvic debulking because patients had the carcinomatosis. We had to do more complex procedures like doing pelvic, periodic lymph node dissection, omentectomies, appendectomies. So we can do 4 quadrants of the abdomen using the robot to make it a big advantage. And we had a very selected case of a recurrent high-grade serous ovarian cancer. She underwent surgery, the primary site of that surgery in 2017. She was free of disease for 6.5 years. There was detected a pelvic recurrence, and she underwent a robotic resection of pelvic lymph node and also a resection of several segments of pelvic peritoneum. So, in conclusion, building a robotic program in Gynae Oncology in the private sector requires commitment from multiple stakeholders. There are remarkable benefits for patients without compromising oncologic outcomes. And this should be stressed to all the board, to all the CEOs of your hospital. Patients with endometrial cancer, in my opinion, are the bread and butter for robotic surgery. Early stage ovarian cancer are also good candidates when well selected, and we have when we have experienced surgeons. They also benefit a lot from robotic surgery. We should select well in our cases for recurrent ovarian cancer to undergo robotic surgery, and we should even select better the cases that should undergo robotic surgery for interval debulking surgery in ovarian cancer. Robotic surgery is also a great tool for complex benign gynecological diseases. So I finished with this picture. So I'm very honored to be a part of the faculty of a robotic surgery course organized by Gynae and ASGO. And I welcome you all to take a look at the website, and hopefully we can see and meet one of these upcoming editions. Thank you so much for listening to me. I'm very happy to share my experience with you, and I'm more than happy to take all the questions that you might have.
Thank you so much. We have Dr. Kosanova and Dr. Mirza online with us. If there are any questions from the audience, they would be very happy to answer.
Good morning, Dr. Mirza.
Can you speak up, please? I can't hear.
So good morning, and it's always a pleasure to hear talks from you, and to looking forward to see you in future soon in person. Thank you again for a wonderful talk. Just a query that have you escalated your treatment depending on P53 in early stage endometrial cancers, and by giving concurrent chemo and adjuvant chemo, especially in stage 1 and stage 2 patients? And what's your experience in giving the concurrent chemo? Is that weekly or 3 weekly, 2 cycles as in stage 3? Thank you.
So your question is addition of immune therapy in P53 or just chemotherapy?
No, just the chemotherapy.
Just the chemotherapy, yes. So yes, definitely what we have seen is that this is this so-called copy number high, the P53 mute population is the patients with the highest risk of relapse and death. Typically, they are serous carcinomas, grade 3 endometrioid, or carcinosarcomas. And in our guidelines, we are now just modifying the guidelines once again for ESGO ESTRO-ESP. And our guidelines, we have said that if patient has also early stage P53 mute patient population, we would recommend go ahead with combination chemotherapy. One can always discuss if it is in the polyp. Do you really need to do that? It's overkill. But you have to think about it. Grade 3 or P53 mute population is a high risk. As you saw in most of the cases, these patients will do much worse. The 5-year survival is about 60%. So yes, we do include chemotherapy to these patients.
Morning, Professor Mirza. Thank you so much again for excellent talk. So I have a question. As we know that there are several types of mismatch repair genes, And as far as I can recall from my fellowship time, that I think MLH1 type is more common in endometrial cancer. So do you think, is there any data which can suggest that which type of mismatch repair gene respond more to the immunotherapy? And I have one question for Dr. Rabia as well.
Thank you. Let me take this question. This is a very important question because we had earlier retrospective analysis of small data which showed that probably the patients who were methylated or mutated were responding differently, and that was also with the MLH genes. But now we have done the classification of two large trials. One is my trial, the Ruby Part 1, and also Ruby Part 2. And we have looked at, Ramesh has looked at GY018 trial and looked at different responses in these two categories, and we don't find any difference. Having said that, I don't think it's a closed capital. We have to work harder because, as you saw, all patients in all trials, first year, 1/3 of the patients are progressing, and we have to figure out who are these patients. So we are working on it, and probably we will find subsets of molecular abnormalities which are not susceptible to immunotherapy. But right now we don't have that.
Thank you. So, Dr. Rabia, thank you so much for
Sure.
excellent talk. This is more practical, I think. So, in the breast clinic, we usually see the patient have been trying for their fertility for a couple of years, sometime, and without any success, unfortunately. So, do you think it's worth referring these patients to you? And also those patients who have low level of MLH1 hormone level. So do you think it's worth referring these patients to gynecologist, or it's better to defer them? And what time would you suggest that we can refer these patients to you after completing their chemotherapy?
Okay.
Thank you.
So, thank you. An excellent question. So it is absolutely worth sending them. As we have said before, the earlier we do it, the better it is. Apart from once you have done chemotherapy for these patients, then usually a gap of 6 months is required because sometimes anti-Mullerian hormone levels that go down immediately after chemotherapy, they tend to build up again, and they do recover sometimes, and we get better response once there has been a 6 months gap from there for fertility preservation or for egg collection. So yes, before any chemotherapy, if a recent diagnosis, then yes, send them immediately. But if a patient has undergone chemotherapy, then in that case, a 6 months gap from is probably required at that point if the patient is on follow-up. Thank you.
I have a question with Dr. Abe as well.
Yes, sure, please.
Thank you for your excellent talk. You gave hope of fertility to some of our cancer patients. My question is regarding the use of ovarian induction drugs in known breast cancer patients.
Yeah.
So what does the data say? Is it a routine practice in some centers in the world?
So actually, for example, one of the ovulation induction drug that we use is letrozole, which you are giving to the patients for breast cancer patients later on as well. So there is safety established for that and can be used. Similarly, the data for gonadotropin for increased breast cancer, there's no evidence to support that it increases the chance of cancers later on. Initial studies had shown there was some studies that showed that probably there is association of ovulation induction with increasing risk of ovarian cancer. But later on, what the meta-analysis have shown is actually it's more those who have had ovulation induction and has still remained nulli gravid. So they did not conceive. So it's the infertility itself which enhances the risk rather than the medication that was given.
Thank you.
Thank you.
I have a question for Professor Mirza. Now we are entering in era where we are doing more and more molecular testing and profiling. Is there any data to suggest that we should be moving more towards neoadjuvant chemotherapy, immunotherapy to protect our patients for distant metastases, especially in high-risk patients?
A great question, thanks. So as you saw that all the trials in the tumors where there was, in the patients where it was macroscopic disease, stage 4, stage first relapse, you saw immense benefit of immune therapy. When we come to the adjuvant, there was no tumor left after surgery. The trial was negative, especially in the pMMR. In dMMR, it's still positive. That tells us that you need some tumor tissue for immune therapy to work. And we are, that's why we have already started. So the data actually on proof of concept comes from colorectal cancer. There's a small study done in these patients which showed 100% response rate, and many patients were not operated after that. There is one small study done with a small number of patients with only 3 cycles of immune therapy in endometrial cancer, which hasn't shown that huge benefit. But we are starting these trials. So in Nordic countries, we are starting a trial where we would be giving chemotherapy plus pembrolizumab to patients who are primarily not able to be go for surgery. So it's a sort of a neoadjuvant. If you're treating these patients with neoadjuvant chemotherapy, we would be, and if they are dMMR or p53 mute, these patients will enter the study. That's a small study, again, proof of concept, but all these studies are ongoing. And I'm sure that the immune therapy would work best upfront, and that would be a great space. The question is, who are the patients who will benefit, and that we have to figure out.
Thank you. Future looks bright and encouraging. Hopefully, with more and more molecular profiling, we can identify these patients that we can do more testing and can start patients and offer them neoadjuvant chemotherapy and immunotherapy, hopefully.
Dr.
Thank
Sadia,
you.
I have a question for the audience, if you can
Sure.
ask that. How many centers are performing molecular classification in Pakistan?
You can raise your hands.
Not many, nothing, nobody is doing that. Oh, but so this is really needed. Let's say it's not the question of cost. If you can do the immune histochemistry, you can do the p53, you can do the MMR status, you can do the also the ER status, all these things. You won't be able to perform poly. I think that would be, at least in Pakistan, it would be essential that you realize that you have to perform molecular classification. Maybe you not poly, but all others to start with.
Actually,
Because
we
your
are doing.
treatment will be dependent.
I think I also forgot to
No,
raise my
we are
hand
doing
because we
to-
are doing it in
Yeah, yeah.
Shaukat Khanum.
Actually, it is being done in all stage 4 cases, but as you said, we should start moving to the earlier stages. And
Yes.
as for with the first histopathology report, it should be done. But in stage 4 cases,
best on
almost all
biopsy.
patients are getting it. Yes.
And based on biopsies, because biopsies are, not left somewhere in the operation theater like a uterus after surgery. So if you can perform it on biopsy, that would be the best, because you get the best results.
Any more questions? No more questions. Thank you very much, Dr. Kosanova and Professor Mirza.
Thank you so much.
Dr. Rabia, for staying with us. It's been great to hear from you about all the recent advancements.
Have a great meeting. Sorry, I'm not there.
Thank you all, the guests, for attending the morning session. I know it is a difficult task, but these are interesting times in oncology as a whole, and especially in gynecological oncology. The molecular targets are being added up, and also advancements in surgical techniques. I thank you once again, all of them. Thank you.
Thank you.
Thank you.
Thank you.